Hello and welcome to the sixth module of PHM 613. For today's class, we'll be discussing access, uninsured, and health policy. And there are three learning objectives. The first is to describe what access is in the context of healthcare service, discuss the effects of health disparities on access. Then, lastly, we are going to discuss just kind of mention a couple of federal policy interventions that have been put in place as a way to increase access to uninsured Americans. So, beginning with access, we have a definition that says access is the process of seeking and receiving care. So, this is might seem like a very simplified definition, but I'm going to elaborate on it a little bit. So, when we're thinking about access, we're thinking about on one end, we're looking at the physical existence of a health resources. I'm going to use for an example. If you were looking at the availability of physicians in an area. Case in point, you're saying Hammond, what is the number of physicians that are operational in Hammond? So you could look at that from a particular area in terms of geographical area, or you could look at it from a more less like from a population angle. So let's use, for example, you want to know how many physicians provide services in Spanish, for an example. So if you are looking at that, it's not just about the physical existence of healthcare resources in terms of number of physicians. You're looking at number of physicians who are able to provide Spanish services. So that is the kind of way to look at it when you're thinking about the physical existence of things. Then that's on one hand. The other one is to look at it from the use of the resources, which is like utilization. So we're thinking, so this thing is available, healthcare resources are available, but does that mean the healthcare resources are being used? So you have to look at from one end the availability of it, and then from the other hand, the use of it. In the use, in the sense of, are there some obstacles that are making it difficult for people to use the services or the resources that are available. So when you're looking at access, you have to look at it from both angles, because if you don't do that, you don't get a full picture of what is going on in terms of the resources. So, simply measuring the number of physicians does not cut it. It's a very insufficient measure of access. You have to look beyond the things. You have to look at the things like what are the processes that is associated with actually seeing, for example, the physicians. The physicians, these processes can become a deterrent. For an example, if there is a Spanish speaking population, let's say there's a Spanish speaking population in Hammond and they don't speak English, or for the most part, it's only the children that speak English, which means for the adults, if they want to use healthcare services, they would need an interpreter, sorry. And if the children are in school, they won't have access to their interpreter. So, which means that if the healthcare provider does not have a Spanish part of the service that it provides, or even as someone to serve as an interpreter for those patients, language becomes for them a barrier to seeing the physicians. So you have to take that into consideration. What are the barriers that make it difficult for people or population to use the services that are, those healthcare resources? So any assessment of physician availability, or I'm just using physician availability in this example, it could be something else. It doesn't have to be physician availability. It could even be preventive care. But just at this point, just put this to mean healthcare resources. So any assessment of healthcare resources has to look into both a provision, look into both that this availability, that this service or this resources is available, as well as measuring the ease or difficulty that is associated with actually gaining access to that resources. So that is a way to look at access. So this looked at the top factors that kind of come into play when interacting with healthcare. So you look at things like ease of access to care, how easy it is to get the access. A place like Hammond, where there are no bus system or train system, transportation becomes a challenge for people who don't have cars. So, meaning that ease of access to medical clinics or may become a problem because of the lack of transportation if that does not exist. And then you then have the issue of privacy, data security, healthcare costs, being able to monitor their own health. So there are a number of things that act as a barrier to access that are not only about cost. A lot of the time, we spent a lot of time talking about cost, that it may look as if cost is the primary concern, but no, there are so many other things that comes into play when we are looking at access. Access goes beyond the financial angle, the financial aspect of it. It also looks at all of these other factors. So, before I talk a bit more about access, this is just a quick summary of the US healthcare system. I'm sure some of you may already be familiar with this, so I'm just going to run through it. So, the US healthcare system um, has a multi-system healthcare model. It has the beverage model, it has the national health insurance model, it has the Bismarck model, as well as it has the private health insurance model. So there's so many multiple models that are working with the US healthcare model. So with the veterans and military and Native Americans, that kind of fits in with the beverage, meaning single payer, single provider. Then you have Medicare and Medicaid that kind of fits in with the national health insurance, single payer, multiple providers. Then you have the multiple payer, multiple providers, which is the insurance-based insurance, employer-based insurance, and then you have the multiple player, multiple provider, which is the commercial healthcare plans. Then we have the unfortunate people who are here, who are either self-insured, who have to pay for everything out of pocket, or who are uninsured because they just don't have another way of getting insurance or getting some kind of coverage. So this is what the US healthcare system is. So one of the challenges the people on this end have is being underinsured. Some of them may be self-insured, meaning that because they are paying out of pocket, they're not able to pay for everything because of how expensive healthcare can be in the US, meaning that for most of them, they may be underinsured, even though they're paying out of their own pocket. And then you have the uninsured completely, and some of that may be tied to immigration status, but some of that could also be tied to a couple of other things that has to do with policy part of it. I just wanted to give a quick overview of that, because when we're talking about healthcare system and access, you need to have that in mind in terms of that, particularly because we're going to talk a little bit about Medicaid. And so this is where that is going to go in, meaning how Medicaid, and especially Medicaid, employer-based insurance, commercial, private insurance, and self-uninsured kind of played in the role with healthcare policy. So, why is access important? So, one of the things, and this is as it is with every healthcare system, uh, the important thing about access or having coverage in the US is health insurance of some sort. In other places, is it just about coverage? It's because of all the multiple advantages you do have that of preventive care. Now, one of the advantages of preventive care is that they are relatively cheaper health services that have a much broader gains to it. So, doing your let me use, for example, pap smear or a mammogram or that of that, they have a relatively small cost to it versus the gains that come out of it. For example, early detection of any sort of cancer and being able to treat that and not having to get into diagnostic procedures is going to cost a lot of money. And so, and also, you get to the point where hopefully it's caught early and you're not going to end up spending a lot of money. Or if you are, you may be able to get intervention, let's say specialist care or hospital care, all of those things. Then you also have the follow up that comes with access and preventive care. That's very important because it does help in being able to track what's going on with the healthcare of the country. It is very kind of difficult for some kind of plans to be made based off on health spending if there's not a very good way of counting those who have healthcare and who don't. So being able to capture in terms of the healthcare in coverage helps in making health plans for the future and as well as the present. So it's very important to have access, not just because it helps you to get the services that you need and get it early enough, but it does help in a much larger, more macro health planning that comes into play in making sure that everybody gets taken care of. And then, of course, individuals who don't engage in preventive care, especially if they don't have access to it, they tend to live a shorter life, unfortunately. And when they do get care, is generally at a much greater expense than if there had been some form of preventive, some form of access to preventive services. So that is one of the importance of access. So, I don't know if some of you hopefully may have been introduced, whether in large part or in small part, about social determinants of health. So basically, with social determinants of health, we are looking at social factors generally that influence health. So in this image is we're kind of summarizing it in terms of you have discrimination or minority stressors being a social determinant of health. You have housing, you have quality, affordable care, health care, stable income or job security, neighborhood conditions. All of these are social determinants of health that have influence in the way one's health status or one's health outcome does. For example, if you live in an area of very poor housing, you are likely going to be exposed to a lot of pollutants and sometimes toxic waste or toxic elements that will, you know, make you sicker or more likely to fall sick as a result. Of course, if your educational opportunities are very low, you are very likely not to be health literate. So you may not be able to engage with the healthcare system all on your own. You may end up not being able to make good health decisions because of education. And this plays a lot of parts with the education of mothers and how that influences the health outcome of the children, whereby the more educated the mothers are, the more healthier or less likely to fall ill the children are. So all of this have very, very direct link to one's healthcare status. So, how does this play into health disparity? So, health disparity is a couple of definitions, but I'm going to take this one that says it's a multidimensional concept that includes such aspects of the population, looking at geographical location and social economic status. So, is looking at all of these external things that is happening just beyond one's individual health choices that one makes, or in terms of whether you are eating healthy or you are exercising and stuff like that. So, health disparity kind of looks at it from a rather multidimensional concept than just individual. So, with health disparity, we are saying in terms of kind of is looking at variations health the variations of health outcome within a population. That's how we are, kind of defining what health disparity is. However, just because we say variation doesn't mean, for instance, I'm trying to find a way to define it. Okay, let me go to the next bullet point that says this is from Healthy People, Healthy People 2020, that says health disparities are systemic, uh, plausibly avoidable health differences adversely affecting socially disadvantaged groups. They may reflect social disadvantage, but causality needs not be established. So this is a very, very, plenteous sense definition, but to break it down, how disparities is looking at the ethical or human rights principles that makes one group of people to have a worse health versus the other group of people. For example, if one has a low income, you are more likely to be uninsured or underinsured versus someone who is earning high. So in this case, this is a variation in terms of insurance coverage, but there's an ethical part of it in the sense that generally the society can be shaped in such a way that some people are kind of kept poor, while some people are kind of more likely to become wealthy. And a case in point would be for most people, if you have an uneducated parent, the likelihood that you will stay uneducated yourself is pretty high. So, but for people who have the highly educated parents, the likelihood that you are going to become highly educated yourself is very high. So there is that kind of societal balance that sort of keeps people in one place versus the other. For example, using gender for an example, they are still at present um, societal balances and views and values that makes women have fewer opportunities than men do, or even when they so-called have the same opportunities, you still have pay gap, gender pay gap playing a role, and you have women you know being paid less than men are. So those are the kind of disparities that come as a result of ethical and ethical issues or human right principles. So those type of variation very much differs from differences that come, I'm going to use an example, genetics. For example, women are more likely to be diagnosed with breast cancer rather than men. There's not really an ethical or social or human rights principles that are at play for that to happen. A lot of it has to do with the breast tissues of women versus men having a different breast tissues. So this is what I mean in terms of when we're talking variation. For us to look at health disparity, we need to be looking at it from an ethical or human rights principle part of it. So health access gets more, policy and public and policymakers' attention because for those who are low income, they generally have a high likelihood of having inadequate health insurance that makes it difficult for them to access affordable for affordable and quality health care, which in turn leads to them having poor health outcomes. But even if we are looking at access in terms of finance, like I said, it's not just about costs that feed into disparities. It's not just, let's just, for example, this service costs, let's say, $1,000. One person can afford $1,000 and the other person cannot afford $1,000. Access goes beyond that. In terms of what brings about health disparity, goes beyond just the access. For instance, you are also going to be looking at the time costs. How much time is it going to cost to be able to go to a certain place? Are the healthcare providers more flexible with making appointments, or are people able, do they have paid time off? If going to the hospital is going to mean me taking time off in which my time off is not going to be paid, it means that I'm going to have to lose income for the period that I'm at the clinic, which would deter me from going to clinic unless things are critical. So, and having, when you have delayed health care, you tend to have poorer health outcome as a result. So when we are looking in terms of health disparities, we go beyond just the cost, especially when we're looking at this in terms of health care services. It goes beyond just the financial access to care. Another thing is, if the society is kind of not set up in such a way to make things difficult. For example, a place like, I'm going to keep on using Hammond because Hammond really doesn't have a good transport system, which is really bad looking at it from the context of healthcare. For women, I'm using women as an example in this case, who generally have to uh, juggle work as well as home. If it's going to take so much time to get to work, do the work in the office, and come back and do the work in the house, they don't have a lot of time to go to the clinics and come back without it affecting their time. So when you have this sort of barriers, that in this case is happening as a result of ethical principles, it makes it difficult to be able to access healthcare and therefore more likely to have poorer health outcomes. So without addressing this, you are not likely going to have helped those who really need help. So there are a couple of statistics that are out there in terms of how health disparity has worked out. You have the African Americans being less likely to pursue healthcare services than white Americans. You have immigrants being 10% less likely to have health insurance than US born people, and Hispanics right now catching up with being the majority of Americans or residents who do not have, who are not insured. And then, of course, you have all the cost barriers, not to mention perceived or real race discrimination or financial discrimination. All of these disparities lead to poorer healthcare for this population that are most affected by it. So this is an image that depicts uninsured rates among non-elderly population. This is from 2010 and to 2021. You will notice that the white and Asians are rather low. Everybody else is kind of climbing high, with blacks, Hispanics, and the American Indians and Alaska Natives being, on the high up. So this is an example of where health disparity is kind of showing up, and this is as a result of race. So there has been a number of things that has been done to improve access, particularly to the uninsured, and but you have to kind of target those that's who need help the most. So who is being targeted? We're kind of looking at, you could look at things like sustained resources, those who have resources but choose not to purchase coverage. They are not so much a target audience, a target population, but it's kind of important to kind of, keep them at the peripheral just in case, and kind of figure out why they are not purchasing insurance. That may be where the barrier is coming from, uh, kind of standing in the way between availability and utilization. So it's always, good to know what's going on there. And then you have those who are acutely uninsured. Maybe something happened and they just lost their insurance coverage for just a short period of time, and it's just a temporal situation, circumstance that's going to be over, and then they get back to being insured. So you have those, and then you have those who are chronically uninsured. Probably their life situation is a bit unstable and therefore leads them to being uninsured for the majority of the time. And then you have the underinsured. They have some form of insurance, but the insurance barely covers much of what they need for it. So those are some of those that the policies are kind of targeting. So there are a couple of policies out there. Some of them look at in terms of developing infrastructure. Some of them are trying to entice healthcare providers to get them to work in underserved areas, and then you have those of them that are kind of combining the two of them, doing both infrastructure development and enticing healthcare providers to work. So a kind of a multi-pronged approach to help, help as many people as possible. So with access and geography, there are a couple of policies that have been out. You have this kind of a policy whereby a place gets to apply for their geographical area to be designed to be assigned as a place of shortage area for healthcare professionals. So when that happens and a place is awarded as being, a designation of, shortage area, they become qualified for what is called federally qualified health centers. So what happens there is that there's some kind of funding for the clinics there, but you also have some kind of funding for loans, student loan repayment, for health providers who agree to work in that place, so that this way they have, kind of increase that threshold or incentive to work in those areas. And then you have the health in the community health centers as well. And then you have the medically underserved areas and then medically underserved population. So with the medically underserved population, is kind of not looking at geographical area. In this case, is kind of looking at uh, populations. An example would be elderly people. For an example, that would be maybe an underserved population. But it could also be those who are, disabled. That's a population, and you could be looking at it from a racial angle of it. So then you have the Conrad 30J1 visa program that was also trying to entice healthcare providers to kind of work in those shortage areas. So this image kind of shows you all the places that you have the populations that are being targeted, and then you have the federal agencies that are in charge of those, and then you have the programs that are at play there, and then you have some non-profit healthcare organizations that are working in those areas. So this is a legend that can show you what the acronyms mean. So you have a number of policies that are all working closely together to try to all working towards increasing access to especially the uninsured, particularly for those who are from underserved areas, so underserved populations, or for an example, rural areas where they don't tend to attract a lot of healthcare professionals. So those are some of the policies that have been in place. But then you have Affordable Care Act with Medicaid expansion. That has been the biggest health policy that the US has experienced in some decades since the establishment of the Social Security and Medicare, Medicaid. So ACA has been the biggest health policy that the US has experienced since then. So, and Medicaid and Medicare was done 1965. So that's quite a long time. So there are a couple of things that ACA did. One of them was to expand employer mandates and provide subsidized insurance that could be purchased in the health insurance exchange. I'm not quite sure how well this insurance exchange are working in practice, but I know that's one of the things ACA did. It also made in the way that it took away pre-existing conditions, as well as made it such that insurance plans couldn't, deny, limit, or exclude some people from getting healthcare plans. And it does also, one of the things ACA did was to expand services to mental health services such that they became essential benefits. Before, mental health was kind of treated not on the same level as physical health, but with ACA, it kind of put it at the same level, whereby you're not treating that as an extra service. It's kind of in the same way that you would cover physical care or physical health, is the same way you cover mental health. Also, insurance were prohibited from capping annual or lifetime spending on mental health, particularly in the way that they couldn't do it for physical health treatment. And also, you know, Medicaid was expanded, which was very, very big one with ACA. So with Medicaid expansion, the attempt was, really, really get towards addressing the low rates of insurance, particularly among those of low economic status. And it did this by, increasing eligibility or expanding the eligibility to ACA. And this also went to individuals and to families as well. And one of the things that happened with the expansion was in increasing the federal poverty level at which a person becomes eligible for coverage under Medicaid. But it does vary. Some states are more generous than others. For example, in Oregon, is up to 300% of federal poverty level, and does not, ask for immigration status. Michigan is lower than Oregon, but it also does, depend on immigration status. So for states that did expand Medicaid, because it's not all states that did, for states that did expand Medicaid, some of the research is showing that there has been a sharp decline in the number of uninsured people, particularly those of the low income population. So this is where we end for today's class. If you have any question, please remember to ask in the Q&A board. Have a lovely day. Bye.